Good evening, students. Evening, students. Let me know if you have joined in. Audio, video, everything is fine. Shall we start? So the topic for today is osteomyelitis and osteoradionecrosis. First, we will deal with this topic of ours, and after this, we will discuss strategy for NEET MDS 2025. All right. So first, these two are very short topics. Not many questions come from these topics. I've just compiled some very important points in these topics so that you can answer your questions. All right, let us start. First, we'll have a look at osteomyelitis and then osteoradionecrosis. All right, so osteomyelitis is the term. Osteomyelitis actually means inflammation of the bone marrow. Right, so in literal terms it means inflammation of the bone marrow. However, the inflammation is not just restricted to the bone marrow, it eventually is the inflammation of the entire bone. All right, so entire bone includes your periosteum, your cortical bone, your cancellous bone, and your marrow. All right, so basically osteomyelitis is inflammation of the bone. Now coming to the classification, there are various classifications. All right, but I am giving you the most simplest one that you need to remember. Okay, so it can be broadly divided into suppurative osteomyelitis and non-suppurative osteomyelitis. All right, now under suppurative osteomyelitis we have acute suppurative osteomyelitis, we have chronic suppurative osteomyelitis, which is further divided into primary and secondary. So the primary chronic suppurative osteomyelitis, it does not have an acute phase. All right, there is no acute phase. However, secondary chronic suppurative osteomyelitis has a acute phase. The chronicity develops after an acute phase. All right, and the third one is your infantile osteomyelitis. Okay, now the second type is non-suppurative osteomyelitis. Now, as the name suggests, non-suppurative meaning there is no pus discharge. So under this we have diffuse sclerosing osteomyelitis, we have focal sclerosing osteomyelitis, which is also known as condensing osteitis. So we have to also know the other names. I'll just highlight it in a different color. So this is your condensing osteitis. The third one under this is proliferative osteitis. Which is also known as periostitis ossificans or caries sclerosing osteomyelitis. All right, and the last one that we have here is osteoradionecrosis. Okay, which I will be covering separately. Now, coming to the etiology. How does osteomyelitis develop? So you people don't need to get worried. I have given some very simple points that you need to remember over here. Now, it can be due to an odontogenic infection, that means an infection from the tooth. All right, it can be due to periodontal disease or periodontitis. It can be due to trauma when there is a compound fracture. It can be hematogenic spread from a different primary location into the region of the jaw. Now, what does this statement mean? This means that if there is osteomyelitis, maybe in some other bone, maybe in the long bone of the body, say of the lower limb or the upper limb. So from that different primary location through the bloodstream, the osteomyelitis comes to affect the jaw region. Alright, so hematogenic spread from a different primary location to the region of the jaw. That means via the bloodstream, the osteomyelitis is spreading from a different location and has now affected the jaw region, although this cause is extremely rare. Okay, now coming to the pathogenesis. Now there are basically two types of pathogenesis on how osteomyelitis can develop. First of all, the first pathway, there would be acute inflammation, which may be related with edema or pus formation, which will cause increased intramedullary pressure and which will ultimately cause vascular collapse, that is stasis or ischemia of the bone, and it will lead to formation of avascular bone because there was stasis of the blood supply and there was ischemia. Now, second pathway, either through pus or organism extension, that is the causative organism or pus travels into the Haversian system or the nutrient canal. So what will this lead to? This will lead to elevation of the periosteum, disrupted blood supply and avascular infected bone. Now this avascular infected bone gives rise to sequestrum. Alright, and this sequestrum is pathognomic of osteomyelitis. Alright, this sequestrum is pathognomic of osteomyelitis. Alright, now let us see the microbiology of osteomyelitis. So it is Staph aureus and Staph epidermidis are the most common organisms. Alright, they are the most common organisms that cause osteomyelitis. Apart from this, we have Peptostreptococcus, Fusobacterium, Prevotella, Klebsiella, Treponema and Actinomyces. Alright, apart from the most common ones, the others I have mentioned. Now coming to the clinical features. Alright, so again, dekho, you don't need to mug up. It is very simple. When there is an acute condition, you will have features as per the acuteness of the disease, and when there is a chronic condition, there will be long-standing clinical features or signs or symptoms. Alright, so now let us see acute osteomyelitis clinical features first. So any acute condition, we are very well aware what will happen. There will be high fever, there will be pain, there will be swelling. Alright, so high fever, localized pain or edema and tenderness, that is pain. Patient might also have trismus, and if it's an acute condition, then patient will have mobile teeth with pus discharge from periodontium, and sometimes in acute osteomyelitis there is a symptom known as Vincent symptom or Vincent syndrome. Alright, this is nothing but paresthesia, or when the osteomyelitis has affected your inferior alveolar nerve. Alright, leading to paresthesia or numbness of the lower lip. Alright, inferior alveolar nerve is affected and patient reports paresthesia of the lips. Vincent symptom or Vincent syndrome. Okay, now these were features of acute osteomyelitis. Coming to features of chronic osteomyelitis. Alright, now chronic osteomyelitis will have a long standing swelling, that will be painful, but not as painful as the acute swelling. All right, there will be a swelling, long standing, painful, but not as in acute osteomyelitis. So painful swellings that are usually not prominent as in the acute osteomyelitis. All right, a common finding is periosteal reaction causing a solid swelling. Okay, so basically what do you mean by solid swelling? A bony hard swelling. All right, bony hard swelling. Okay, the important point, sequestrum formation and fistula formation. This is one of the hallmark of chronic osteomyelitis, and in some cases also further, if it is not treated, it might further cause exposed bone. Okay, now coming to the diagnosis. So basically you can use any, any imaging modality, that is either your OPG, CBCT, CT or MRI. Now the most important thing here is there has to be 30 to 40% reduction of mineralization of the bone. All right, or there has to be 30 to 40% loss of mineralized part of bone. Only then osteomyelitis would be evident on a radiograph or on any imaging modality. Now apart from this, there is something known as bone scintigraphy. Now if you are suspecting multiple sites of osteomyelitis in a patient's body, okay, if you're suspecting multiple sites of osteomyelitis in a patient's body, so bone scintigraphy is used to identify multiple foci or multiple sites of osteomyelitis. Only in that case you use a bone scintigraphy. Now coming to the radiographic appearance, there would be a moth-eaten appearance. Okay, there would be islands of sequestrum, that is necrosed dead bone. All right, there would be appearance of a sclerotic bone, and when there is sequestrum, all right, whenever there is sequestrum, you will also realize that the body's mechanism would be to isolate the sequestrum by new bone formation. So there would be a sheath of new bone, that is your involucrum. So two important features on radiographs, sequestrum and involucrum. All right, and this involucrum is separated from sequestrum by a zone of radiolucency, all right, and stippled or granular densification of bone by subperiosteal deposition of bone. So where there is a periosteal reaction or periostitis, in that case there would be stippled or granular densification of bone by subperiosteal deposition of bone. Okay, now coming to the treatment. First we are going to see the conservative treatment or the medical management, and then followed by the surgical one. Alright, now treatment can take place either inpatient or the patients who are hospitalized, or patients who are being treated on OPD basis. Okay, now the first regimen here talks about hospitalized or medically compromised or immunocompromised patients. So in such patients, the first thing that you start with is penicillin G 2 million international units every 4th hourly, along with metrogel 500 milligram every 6th hourly. All right, so this is IV. This is IV. Now after 48 to 72 hours of administering these doses, if there is improvement, you can switch to oral. All right, that is penicillin V 500 milligram per orally every 4th hourly, along with metrogel 400 milligram per orally every sixth hourly for 4 to 6 weeks. Okay, or you can treat with ampicillin or sulbactam 1.5 to 3 grams IV every sixth hourly, and after 48 to 72 hours, if there is improvement, you give augmentin 1000 milligram per orally BD again for 4 to 6 weeks. Okay, this is regimen 1. Now regimen 2 for outpatients. Penicillin V 2 grams plus Metrogyl 400 milligram 8th hourly per orally for 2 to 4 weeks after last sequestrum removal and patients without symptoms. Alright, okay, so you have to give this regimen 2 to 4 weeks, for at least 2 to 4 weeks after you have removed the sequestrum. Alright, and the patient is without any active symptoms of osteomyelitis to keep the disease under control. Or you can give clindamycin 300 milligram to 450 milligram every 6th hourly per orally again for 2 to 4 weeks. Okay, so these are your regimens. Okay, now coming to the surgical management. Again, we don't have to go into the techniques. I will verbally explain you. Okay, these are 4 most important things. First is sequestrectomy. Sequestrectomy, that is removal of sequestrum. Okay, then basically what is sequestrectomy is you identify the sequestrum and you just remove that part of the bone which has become sclerosed or which has turned into a sequestra. Okay, now the second one is sequestrectomy and saucerization. Sequestrectomy and saucerization. So in this second technique, what you're doing, you're removing the sequestra and you are, like how you do peripheral osteectomy for cysts and tumors, you just remove another layer of bone and give it a saucer like shape. You give it a saucer like shape. You remove the sequestra and you scrape some more bone and you give a saucer like shape, saucerization. Okay, now the third one is decortication. All right, so in the cases where the cortex is the problematic area or where the involvement of the cortex due to osteomyelitis is very frank and very evident, so what you do, you remove that portion of the cortex or you remove that portion of cortical bone. That is decortication. So decortication is nothing but removal of cortical bone. Okay, now in long standing cases which are not responding to any antibiotics or recurrent cases or which have become dormant or refractory to treatment, you do resection and reconstruction. Resection, that means you cut the bone from there, you resect the bone, remove that block of bone and reconstruct it. All right, this is resection and reconstruction. So these are your possible surgical modalities of treatment of osteomyelitis. Okay, now there are a few associated syndromes with osteomyelitis. The first one is, there are just 2 syndromes and you can remember them very easy: Sapho syndrome and CRMO syndrome. So basically Sapho is nothing but synovitis, acne, pustulosis, hyperostosis and osteitis. Alright, this is the These are the components, or this is the full form of Sappho syndrome. Now CRMO, chronic recurrent multifocal osteomyelitis. All right, so what is this condition? This is an autoimmune condition. Okay, it's an autoimmune condition. This usually happens due to a autoimmune mechanism in the body. It is usually not due to trauma or infection. All right, and this results in bone inflammation, pain, and damage to the bone. All right, and it is severe form of chronic non-bacterial osteomyelitis. So the osteomyelitis arising due to CRMO, like I said, it is not due to any organism, so it becomes non-bacterial in origin. The symptoms are bone pain, joint swelling, and fever. All right, the symptoms are bone pain, joint swelling, and fever. So it tends to mimic your acute osteomyelitis. Patient will have swelling, tenderness, fever, but no, it has a autoimmune etiology. Okay, so that is what we have in osteomyelitis. Okay, now we are going to start with osteoradionecrosis. Okay, so everything in osteomyelitis is clear. Is everything clear in osteomyelitis? Should we proceed with osteoradionecrosis? Okay, fine. Now coming to osteoradionecrosis. So basically osteoradionecrosis is a type of osteomyelitis. Okay, but it is non-suppurative. Now let me tell you, osteoradionecrosis can get secondarily infected also. So due to secondary infection, it can have pus discharge, but inherently by its own nature, it is a non-suppurative form of osteomyelitis. Fine. Now, osteoradionecrosis is happening due to radiation exposure. Fine. So whenever there is radiation exposure, one thing will be for sure in osteoradionecrosis, that there is some radiation exposure. Okay, so the most important thing is radiation. So osteoradionecrosis is described as exposed necrotic bone due to radiation. So the patient will give you history of radiation therapy. Now specifically, if we talk about our orofacial region or head and neck region, in such patients we mostly see patients developing osteoradionecrosis of the mandible due to radiation received for oral cancer. All right, so if the head and neck region has been irradiated, or if the patient has received head and neck radiotherapy, then the patient is more predisposed to developing osteoradionecrosis of the mandible. All right, so now the next point is important. It is a non-healing condition. There will be hypoxia, hypocellularity, and hypovascularity. Okay, so radiation in excess of 50 grays kills the osteocytes and results in progressive obliterative arteritis, which is also known as endarteritis, periarteritis, hyalinization, fibrosis, and thrombosis of vessels. All right, so basically in simpler terms, what is happening? Radiation हुआ jaw को. So what will happen? Due to the killing of osteocytes, what will happen? The blood supply will get obliterated. alright, which will result in hyalinization, fibrosis and thrombosis of vessels, ultimately giving rise to or causing hypoxia, hypocellularity and hypovascularity, due to which it will result in necrosis of the bone. Okay, now I have seen a few questions on the next point. It is a triad of, initially, now the concept has changed, but for answering the questions, it is a triad of radiation, trauma and infection. Okay, so it was thought, or it was hypothesized, that first the radiation happens and followed by trauma, either due to, for example, let's say due to extraction of a tooth or something. For then, if radiation is present, then if patient undergoes some trauma followed by any infection to that region, so these three things give rise to osteoradionecrosis. Although now this concept has become older, okay, but there are a few questions. So this is your sequence: radiation, trauma, infection. Okay, now what would be the clinical features or symptoms? There would be pain and there would be evidence of exposed bone. So the exposed bone will be very lifeless. It will be dull yellow, grayish in color. Grayish yellow in color. It would be associated with trismus and halitosis. And mandible is more commonly affected bone as compared to the maxilla. Mandible is the most commonly affected bone due to its single blood supply. Alright, now long-standing osteoradionecrosis can get infected. Alright, they can secondarily get infected. Long-standing osteoradionecrosis can have pus discharge. Alright, apart from that, they can develop fistula and they can develop pathological fractures due to weakening of the bone. So they can develop fistula. The fistula can maybe drain pus, okay, or there can be some fluid discharge from the fistula. Alright, so there will be an extraoral fistula that can develop. The fistula will have a direct communication with the bone at the site of osteoradionecrosis, and also due to weakening or of the bone due to hypovascularity, hypocellularity, there can be a pathological fracture. Okay, now there are certain points that need to be taken care of during the treatment. Okay, so if there is infection, first of all we control the infection, okay, followed by supportive treatment. Okay, for in supportive treatment you can give nutritional supplements to the patient. All right, calcium, B12, you can keep the patient on a fluid diet, because if the patient is unable to chew or if the patient is having trismus. So supportive and symptomatic treatment. So in supportive treatment you basically have your symptomatic treatment for pain relief and supportive treatment. You aim at improving the overall condition of the patient by enhancing patient's oral intake, by putting the patient on liquid diet, and by putting the patient on supplements. Okay, now gentle irrigation of exposed bone. Okay, gentle irrigation of exposed bone, not forceful irrigation but gentle, not forceful, gentle irrigation of the exposed bone, and debridement and removal of exposed bone and packing with zinc oxide and neomycin. So what is debridement? If you feel intraorally or if you see that there are certain bone chips or bone fragments, if you feel there are certain bone chips or bone fragments that are lying loose, alright, or that are very they're attached with a very little soft tissue attachment, you can remove those bone chips or fragments of bone. Okay, you can remove it in the OPD and pack the remaining area with zinc peroxide and neomycin. Okay, so irrigation and packing is repeated weekly till sequestration occurs or granulation tissue forms. All right. Now that means till sclerotic bone forms. This was completely dead, lifeless bone. We either have to, so we have to achieve, our aim is to stop this process. Our aim is to stop this process. So sequestration is nothing but sclerosed bone. Okay. So we have to achieve either formation of sclerosed bone, or we have to achieve granulation tissue forming over bone. Alright, so till then you continue your irrigation and packing. Okay, apart from this, what we can do is holes are drilled in lingual cortex to form bleeding points for revascularization. So if only the buccal cortex is involved, and if you feel that the lingual cortex is healthy, what you can do is you can drill holes or punch holes in the lingual cortex to induce bleeding, and this will help in revascularization. All right. The next treatment modality is ultrasound therapy plus debridement. So what does this help in? Neovascularization and neocellularity. Okay, you don't need to go into the mechanism, you don't need to understand how, why it is done. All right, and if nothing works, then resection with adequate margins. All right, then resection with adequate margins, and in this case usually you leave it to heal by secondary intention. You usually do not go and do a plating, because plating or drilling screws in the bone is further going to increase its trauma. All right, so that is going to be of no help. So you just resect with adequate margins and leave it to heal by secondary intention. Now the most important thing is hyperbaric oxygen therapy, which is very useful in osteoradionecrosis. All right, so basically hyperbaric oxygen therapy, please understand, hyperbaric, baric means atmospheric pressure, baric. All right, so atmospheric pressure, 100% oxygen in a pressurized state. All right, we are delivering 100% oxygen to the patient in a pressurized state. Now let us see, there are stages of hyperbaric oxygen therapy. Okay, so this is according to the Mark's protocol. Stage 1, first thing that we are doing here is 30 sessions. Okay, 30 sessions or 30 dives, they are also known as 30 sessions or 30 dives of 100% O2 for 90 minutes at 2.4 atmospheric pressure. All right, at 2.4 atmospheric pressure, 30 dives of 100% oxygen for 90 minutes at 2.4 atmospheric pressure. After this is complete, you examine the exposed bone. Okay, now if there is response, all right, in that case you go ahead with 10 more sessions of 100% oxygen at 90 minutes for 90 minutes at 2.4 atmospheric pressure. All right, that means the patient has responded, and here you end your treatment. Okay, so during the stage 1 there will be no surgery, no antibiotics, saline rinses only when the patient is undergoing a stage 1, or when the patient is undergoing is in the stage 1 of hyperbaric oxygen therapy. Now, if after stage 1 therapy there is no response, let's say there is no response, so after stage 1 you subject the patient to surgery. If the inferior border of the mandible can be maintained, good. If not, then we cannot help it, but we try to maintain the inferior border of the mandible. So basically you do a resection, you do a marginal resection, or in some cases marginal resection is not possible, you have to do a segmental resection. In that case you cannot maintain the inferior border. So after the surgery there will be further 10 sessions or 10 dives of 100% O2 for 90 minutes at 2.4 atmospheric pressure. Okay. Now, if there is response, all right, that means there is healing without exposed bone. That is a stage 2 responder. Okay, stage 2 responder will undergo surgery and then will heal, then will again undergo 10 sessions of hyperbaric oxygen therapy, and then will ultimately heal without exposed bone. Okay, now after stage 2, even if after the patient has undergone surgery, all right, and after 10 sessions, again after surgery, after 10 sessions of HBO therapy, there is still no response, all right, so then you have to go and do the complete excision. In case if you have left the lower border behind, if you have left any non-viable bone behind, thinking that it may get revived or giving it a chance, then you have to, and if the patient is a no responder, then in stage 3 you have to go and excise the complete non-viable bone. You have to go for fixation of mandibular segments. So this is the last resort. What we are talking about here is the last resort, followed by 10 sessions of 100% O2 for 90 minutes at 2.4 atmospheric pressure. And after that you have to reconstruct by a free fibula graft or anything. You can reconstruct after 3 months and you do not require any further hyperbaric oxygen therapy. Okay, now the other part of this is after stage 1 or during stage 1 therapy, all right, if the patient develops a cutaneous fistula, a pathological fracture, or resorption of inferior border, okay, during stage 1 treatment, if the patient develops this, that also means the patient is refractory to the ongoing treatment. So in that case also you will go for stage 3. All right, you will go for stage 3. Okay, so basically in HBO therapy, just remember, when you're giving 30 dives, when are you giving 20 dives, what is the concentration of oxygen, what is the duration of per sitting, what is the atmospheric pressure. All right, this is the Mark's protocol of hyperbaric oxygen therapy. This is all that you need to remember. More than this is not required in either osteomyelitis or osteoradionecrosis. Fine. Now we will discuss strategy for NEAT. Okay, so your date of exam is 19th April. All right, fine. Now from today we have exactly 2 months. Okay, so I am going to give you a few tips on how do you prepare in the last 2 months. Okay, last 2 months of your preparation, how do you have to deal with it so that you can do the maximum revisions. So now the time is for smart work. Your hard work is over. Okay, you all have worked hard. Please believe in yourselves. Please have a positive outlook. Now is the time for your final show. Your smart work has to start now. Okay, if I calculate exactly, we have 58 days. Okay, from these 58 days, your last 15 days has to be only revision. Okay, and when I mean what I mean by revision, only MCQs and only those topics or referring notes for topics which you are weak in. Alright, so this is your last 15 days. Alright, now from 58, if I subtract 15 days, you are roughly left with 43 days starting tomorrow. Alright, okay, now in this 42, 43, 44, whatever days, you have to do a complete wholesome smart revision. Okay, you can devise your own strategy to revise. I'll tell you what I feel that you people can do to the best of your abilities. So if you divide these 43 days amongst all your subjects, you get roughly 2.5 days per subject. Okay, now it can depend, varying individual to individual. Some might need 3 days for prostho, some might need 4 days for prostho, some might need only 2 days for oral surgery, some people might need 3 days for oral surgery. So per subject, how you divide these 43 days, I leave it up to you. Okay, now how do you club your subjects? There are many subjects which are overlapping. Okay, so you can combine subjects like physiology, biochemistry, general medicine. Okay, you can, when I mean combine, what do I mean? That today if you have read physiology, or today if you have read biochemistry, all right, then the next 2 days you can give to physiology. After 2 days of physiology, you can give another 2 days to general medicine. Another example, if today I start with 2 days of anatomy, I can give 2 days of anatomy maybe, then followed by 2 days of general surgery, followed by 2.5 whatever you are required for oral surgery. So when you combine subjects, what happens? Your concepts, the interrelated concepts build up and they start getting stronger. Okay, so like this, for example, you can combine oral medicine, oral radiology, oral pathology. Okay, you can combine such subjects. You can combine DADH. So you can make your own timetable starting tomorrow. Today you can make a rough draft of your, yes, I'll come to the grand test part also. All right, I'll come to the grand test part also. So you can combine your subjects. Now when you are combining your subjects, in every subject, I want you all to list down, you will definitely have some strong topics and your weak topics. So today when you make your timetable for the next 2 months, in every subject, take 4-5 sheets of paper, start by writing date wise what you want to revise when. Okay, and in that also, on another sheet of paper, list down your weak subjects, like जो मेरे को बार बार questions इसमें गलत हो रहे हैं, या I'm not able to retain the theory of this particular topic. All right, you make down a notes, you make down your brief outline that what topics, और ये सब्जेक्ट तो मेरा बिल्कुल गया गुजरा है, और फॉर एग्जाम्पल माई DADH इज वेरी स्ट्रॉन्ग, आई एम एबल टू डू इट क्विकली. Okay, you list down that. Fine. So don't worry if it is taking little more time. Don't worry. See, I would not suggest any minimum time for your notes, Bhavna, because that will only create undue pressure on you. Okay, that is why I'm saying divide your notes. Some portions you might be remembering very well. All right, so for that you just flip. For example, oral surgery की बात कर लेते हैं. Impaction and exodontia. For example, your impaction exodontia, I'm just giving an example. Okay, for example, your impaction exodontia is strong, so you can just flip. All right, you can quickly read and flip. Okay, now suppose if 2 days today you have done your oral surgery, you can give a oral surgery test, or you can practice MCQs of oral surgery, or you can, I would give one more suggestion, divide your day. Try to start your day early. Okay, apart starting your day, give yourself adequate time for, you know, having your meals, bathing, resting. All right, so I would suggest that you divide your day into morning and evening. All right, your exam is 2 to 5, it is from 2 p.m. to 5 p.m. this time. Okay, so divide your day. Like morning, when you are the most active, all right, I would suggest that you try to attempt questions, or try to read questions, or do practice MCQs, previous year's questions in the morning, along with revising your notes of the weaker topic. Okay, in the evening, or when you are post lunch, post dinner, when all of us feel a little drowsy, little sleepy, I would suggest you to either open videos, whatever videos we have on the YouTube, video discussions, notes, lectures. If you want to revisit any video of the lectures, go revisit them. Okay, so now you have to do everything in a time bound manner, and your time from, try to, now the time is time bound studying. Okay, so identify your weak subjects, cover them first. I would suggest do all your what do you call, your medical or basic sciences subjects first, because we all tend to be a little lagging in those subjects. All right, so because every student has his or her own individual needs, I'm not giving a proper timetable, I'm just giving you an outline of what needs to be done. So first of all, divide your day, morning and evening, pre-lunch, post-lunch, or whatever, from the time that you are waking up. Okay, take 1 hour to wake up, wake up, get ready, pray, meditate, whatever is comfortable to you, followed by starting your day by either attempting your reading your weak topics, or attempting questions, doing previous year's questions. Then in the afternoon, after lunch, take a little break. After taking the break, if you want to see a video, or if you want to, something which does not make you, because we are all drowsy during that, do something which is interesting, or which will utilize less of your energy. All right, now start giving your tests. This is the time to give your tests. Complete your tests, try to do as many as questions as possible. Okay, try to read notes in a way that you have to read them in a way that you're not wasting unnecessary time, which the things that you think that you remember, try to substitute less time for that. All right. So in this particular way, you will have a comprehensive revision of your subjects. Okay. When you have a comprehensive revision of your subjects, then in the last 15 days, you only have to have questions. Try and do as many as questions possible. Your questions can be previous year's questions. And in the last 15 days, if you think that you're forgetting, there are certain topics, सबके साथ होता है, कुछ ऐसे topics होते हैं कितना भी पढ़ लो हम भूल रहे हैं, और अगर वो important topics comprise करता है तो just revise or read notes of forgetful topics. Okay, so this is what I would like to suggest. If you have any more questions, I can answer. Okay, don't worry, sleep well, eat well, pray. You all have done hard work, you all have prepared well, you all will come out with flying colors. Now it is the time to forget everything and just read and practice MCQs, for the next 2 months. Leave your internship, leave your clinics, leave everything. Don't get distracted. Just study, and I'm sure all of you will get good results. Okay, so if you have any more questions, I would like to take that. And the next oral surgery session we will have on 27th. That will be a MCQ based discussion. So you put in all your doubts on the group. I will take all the doubts verbally here on YouTube. So Bhavna, I would suggest at least 2 grand tests per week. All right, at least 2 grand tests per week. If you have to ask me, at least 2, not less than 2. That will put you in the mode of practice. That will give you the speed. That will give you, initially you might be slow with your grand tests. Initial few grand tests you might be slow. Don't worry. In the grand test, develop a habit of reading your questions carefully, looking for the keywords, answering carefully, and I would suggest by 6, when you have touched 6 or 8 grand tests, you will automatically speeden up and you will get into the temperament, and it will also help you giving a exam, mimicking an exam hall like of environment. Okay, any more doubts? So 27th oral surgery session, we will have a MCQ based discussion. We will have on 27th. Apart from this, Chetan sir has taken a session on examination pattern, all right, in where he is very nicely discussed what is to be done on the day of the exam. So that is available on YouTube. Please go and watch Chetan sir's video. He has very nicely explained everything that is to be done on the day of the exam. Okay, I have tried to give you a brief idea of what is to be done in these last 2 months. Do we have any more doubts? Are there any more doubts, any more questions regarding your exam strategy, preparation strategy, anything that you want me to enlighten upon? Shall we wind up the session? Okay, so happy studying, dear students. Wishing you all the very best. May you all come out with flying colors. How to improve GT score? Practice, practice, practice. Okay. So you try to attempt GTs. Okay, and I would suggest wherever you have gone wrong, बस उतना ही discussion detail में देखो. And if you feel like you want to go back, consult your notes or your lectures, just quickly, once you get your GT score, all right, figure out where you have gone wrong, try to zero down either which subject or a particular topic of a subject. Just go back, all right, and see what is given in your notes, what is given in your lectures. All right, so what will happen, it will reinforce. Maybe something from the notes has slipped out of your mind, maybe you have forgotten something, or maybe you overlooked something in confidence, so that will get reinforced then and there. Okay, Bhavna, are all your doubts clear, Bhavna? Any other doubts? Okay, very good. So I wish you all the very best, dear students. Happy studying, believe in yourself. You have time to revise thoroughly, so don't panic. Just proceed with a calm mind, and now is the time for smart work. All right, thank you so much and wishing you all the very best.